Awesome. Well, good evening. Thank you so much for coming tonight. I've really enjoyed working here at Pennington, but I've been here for a year, but I've also been working with individuals who have dementia since graduate school, which I left in 1995. So I'm also having coming up on my 20-year anniversary of being a licensed psychologist. And my area of specialization is with neuropsychology, which is a study of the relationship between the brain and our behavior and our moods and emotions. And if you're living with someone who has dementia or Alzheimer's in particular, then you know that the brain has a very large role in determining behavior and moods and motivation and all sorts of things. Today, what I want to talk about is starting the journey once you have a diagnosis of dementia. I know you've heard some already about how you arrive at that diagnosis of dementia, and we were having an interesting conversation before people started arriving about sometimes you don't even really have a specific diagnosis, you just know that there's dementia, and so you may still have questions even though you've been on this journey for quite some time. So I won't hit too hard on those issues of diagnosing dementia. I do want to talk to you a bit about cognitive testing and neuropsychological assessment, because that's something I know a lot about. And it's something that can be really useful to you not only at the beginning and getting a diagnosis, but also throughout that journey with dementia and trying to get an objective read of how things might be changing over time. So my understanding is we're going to hold questions until the end. And so write some down if you think of them. I'm happy to answer any questions that you might have. As Dr. Keller was saying, I do work across the street with Jefferson Neurobehavioral Group. And over there, I do therapy. I see people who have depression. I see people who have anxiety. I also do a lot of assessment. And I get a lot of referrals from the neurologists here in town for people complaining of memory problems. And that's usually how people come to see me to have cognitive assessment, is that they've gone to their first, usually family doctor, and said, I've noticed that my husband doesn't quite remember as well, and he's saying the same thing over and over again. What do you think's going on? They may do a quick little test in the office, clock drawing, or a mental status exam, and say, I really want you to go see my friend, Dr. So-and-so, the neurologist. So that's usually the next step. And then very frequently the neurologist will say, I'd like to get some more objective data, both of the structure of your brain, MRI, and the functioning of your brain, and that's where cognitive or neuropsychological testing comes in. You can have a very normal-looking MRI for your age and still have measurable memory problems. So it really does add something to what the physician knows about what's going on. I know that it's been reviewed with you that dementia, and in particular Alzheimer's, is really a rule-out diagnosis. You just end up ruling out a lot of other potential causes of memory problems, and what you're left with is the best explanation. The only definitive way at this point to diagnose Alzheimer's is by biopsy, and we don't do that on people who are alive. You need all of that brain tissue, so we don't go in there unless there's some kind of cancer. We don't go in there and mess around with the brain if we can help it. So what we try to do is arrive at the closest explanation of what's going on. Because I'm going to be talking about the earlier stages of dementia, I wanted to tell you a little bit about how dementia gets staged. If you've got someone you're working with or whom you love or know who has dementia, have you been told that they have a stage of their disease? Raise your hand if you have been. And was it mild or moderate?
Moderate to the third stage.
Moderate to third stage, okay. And what about you? Moderate. And then you said moderate as well, okay. In diagnosing, we do think about dementia as being on a continuum. And in order to arrive at where we might put someone on that continuum, we look at lots of different factors. And I've listed some of the main ones here. This is from a scale called the Clinical Dementia Rating Scale. And in addition to all these tests that we do, we also look at functioning. And these are things that you may notice are very pertinent to when you first started noticing problems in your loved one or the person you know who has dementia. And So not only do we look at these objective tests of memory, but we also sit and talk with people who know that individual very well and say things like, do they take showers without being reminded, or do they have to be reminded to brush their teeth? Or we ask questions about problem solving. Would this person know what to do if a small fire started in the kitchen? Do you think that they would know what to do about as well as they used to, or not as well as they used to? And you can see that not only by the memory testing and the imaging and the lab results, but also in terms of daily functioning, a pattern starts to emerge that really there's a certain amount of forgetfulness, and this is good news for most of us. There's a certain amount of forgetfulness that's not uncommon for age. It's called benign forgetfulness. We tend to, our brains don't process as quickly, think just a little bit more slowly. So this has probably happened to you. I know it happens to me. You say, oh, I saw so-and-so. What's her name? Well, I'll think of it in a minute. And then you do think of it in a minute, right? That's not a true memory loss. That's a little bit of a delay or a lag, and that's actually pretty common with aging. So you can see in this first column, if you're evaluating someone and they have no loss of memory, they're fully oriented, and that means that they know the date, the year, where they are, what's going on, who they're with. Judgment is as good as ever. They're independent with driving to the coffee club and going to their workplace. Their hobbies are well maintained. They can still wash the dishes with no problem, and then they're fully capable of self-care. You're not really talking about someone who's yet on the dementia continuum. But then there's this category called questionable. And if any of you know someone who's been diagnosed with mild cognitive impairment, raise your hand. You've heard that term before? That's a newer concept for us in thinking about how dementia evolves over time, is this idea of mild cognitive or neurocognitive impairment. There does seem to be a certain subset of folks who have some measurable memory problems, but who are still very high functioning. And for some subset of those folks, they never really get worse. But it does put you in a higher risk category for them eventually converting to dementia. So it's been placed in our thinking about that continuum of dementia. You go from no evidence of dementia to questionable evidence of dementia or mild cognitive impairment, and then you move into the mild stage of dementia, and that's where you can see the symptoms that are listed in that last column. People definitely have problems with memory to the point that it's interfering with their ability to do things day to day. They have trouble with time relationships. They'll say, oh, you remember we went to so-and-so's yesterday, but it was actually last year. You know, they get a little disoriented in time. Also, people in the mild stage of dementia can become what's called geographically disoriented. So in familiar environments, they do fine, but if they're outside their normal space, they get a little disoriented. So going to a new doctor's office becomes very difficult, or even going to a doctor's office you haven't been to in a while might become difficult. Judgment and problem solving become a little bit of a problem, so maybe they start writing checks for magazines that you don't need. That would be bad judgment. But to the casual observer, they still have good social judgment, so they're able to carry on a conversation. And so to the casual observer, people might not notice that there's anything wrong. But if you're living with that person, you would notice that something's wrong. That's another characteristic of the mild stage of dementia. And then you'll start to notice changes in the home where they can do the laundry, but then they don't put it in the right place, or they only do 2 pieces at a time, or they wash reds with whites, my personal pet peeve. So little errors like that were things that used to be very easy. Or putting the dishes away in the refrigerator, you know, just small errors, but enough that it's different from their usual level of functioning. And then also in the mild stage of dementia, frequently people will start needing prompting with self-care. So they can still take a shower all by themselves and get dressed and get ready in the morning, but you might have to remind them that they haven't had a shower today. You know, you might have to say, hey, it's time for a shower. Did you take your medications? So the mild stage of dementia is where I'm going to really focus today. I'll also talk about the transition from the mild stage to the moderate stage, because I think that's a real challenge for a lot of families and a lot of care partners. Let me tell you a little bit about neuropsychological. Hi. Sure. A little bit about neuropsychological assessment in particular. This is one of my areas of expertise. The purpose of this type of assessment is, again, as I mentioned to you, to augment what the physician is already gathering. The physician is trying to get a very good picture of the brain to look for any kind of structural problems. They're going to look at lab work. Dr. Gahan went over all this with you guys, I think. Lab work to make sure there's nothing correctable, like a vitamin deficiency. And then to augment that, what we do is we actually sit down with the individual who's having the memory problems and make them remember things, and then measure the rate at which they forget that information. Raise your hand if you've had a loved one with dementia who actually had a cognitive assessment. So several people. A lot of times a physician feels comfortable, it's pretty obvious from the symptoms, and it's very stereotypical for Alzheimer's, that they'll go ahead and diagnose without a cognitive assessment. Of course, I'm biased. I'm going to go ahead and tell you that right up front. I always think it's a great idea to have a cognitive assessment because it gives you an objective measure of where that person is in terms of functioning. And it can also serve as the basis for making really specific recommendations about how can you deal with this person's particular cognitive deficits. Because you know that with different types of dementia, you're going to get different patterns of cognitive deficits, different patterns of behavior problems. And it is fairly time-consuming because we do try to get a nice overview of lots of the things that the brain takes care of for you. So I'm going to talk about the temporal lobes in a minute because I have a really good brain picture and I want to show you my brain picture. But we definitely assess memory, but not just, there's no just one test for memory. We look at verbal memory, which would be things like your memory for conversations. And you may notice that your loved one with dementia forgets things you've told them, and that's verbal memory. That's your memory for things people have said to you. There's also visual memory, another big area that we test. Visual memory is memory for where I put something down, so people with dementia tend to misplace things, or how do I drive from here to my daughter's house, so they might get lost even to familiar places, and memory for faces, because that's really more of a visual type of memory process. So we test both. We test verbal and visual memory. We also look at other domains, and the way that we do this is one-on-one with a testing technician. We try to eliminate a lot of distraction in the environment. It's mostly paper and pencil type tests. We do have 1 or 2 computer tests. And I can't tell you how many people I've had in my office say, oh, I'm so bad with the computer, don't put me on the computer. But it's really just a clicking the button kind of computer test. It's not a test of how well you can send an email or put an attachment on an email or anything like that. And then the way that we interpret the results is that we look at the scores of that individual as compared to other people their age with their same level of education. So we have norms that have been established, because you don't want to get compared to 18-year-olds. Trust me, I don't either. They're very, very efficient thinkers. They're very efficient cognitively. So what we do is we level the playing field on age, because there are some changes that happen normally with aging in terms of thinking abilities. And then we also level the playing field on education, because that is a factor with some tests that can skew results or make people appear to be deficient when they're really not. They just, particularly in the cohort that was born in the 1930s and 1940s, I've had many people come to my office and say, yeah, I went through 6th grade and then I had to go to work, you know, on my family farm, or my dad died and I had to help out the family. So limited formal education, we don't want people to be penalized for that on the testing. We're not trying to test how well educated they are, we're trying to test those basic cognitive functions. Then, and this is the reason I always advocate for getting formal testing, is that then you can track changes over time much more efficiently, because then you're comparing a person back to their own baseline. You're comparing them back to their results from a year or 2 years ago, which dramatically increases our sensitivity at being able to detect changes. So if you have a loved one who's in the mild stages of a dementia, it might still be worth it to have some assessment. In the moderate stages, I think you probably have enough on your hands and you've got enough going on that you may not need to start down that road if you haven't already gotten on that track. Here's my brain picture. Okay, so the temporal lobe, your eyes are up here in the front by the frontal lobe. In fact, they sit sort of right under the frontal lobe. The temporal lobe is right here above your ears. And different areas of the brain are roughly analogous to different functions. So And this is very oversimplified, but the temporal lobes really are very, very important for memory. And in particular, the temporal lobes are where we see damage and changes in Alzheimer's disease. There's a structure in the temporal lobe called the hippocampus, and then right next to that, a really important part of our cortex called the entorhinal cortex. And those structures in the brain are where the cells are. I know Dr. Gahan talked to you about acetylcholine. That's where many of the receptor sites for acetylcholine reside. It's there in the temporal lobes on the left and the right. For most right-handed people, we are left hemisphere dominant for language, which is kind of interesting. For most left-handed people, you're also left hemisphere dominant for language, but there's a certain smaller percentage of people with left-handedness who are right hemisphere dominant for language. What that means in terms of cognitive assessment is that when we're looking at verbal memory, and if somebody's really having trouble with verbal memory and they're right-handed, I can hypothesize that there might be something going on in their left temporal lobe, because that is the side of the brain that's important for language, and the temporal lobe is very important for memory functioning. And so when we do the neuropsychological testing, we can make hypotheses about where someone might be having a problem, and different profiles can be indicative of different types of dementia. So you can see that it really adds, again, I'm biased. So the other thing I wanted to show you about this brain drawing is that when you move from the mild stage of Alzheimer's into the moderate stage of Alzheimer's, more cell areas become affected, and so you'll start to notice changes in more cognitive areas. So not only memory, but also judgment, problem solving, speech and language. People will have a really hard time finding the right word. They will have a really hard time expressing themselves with language, and they may have a really hard time comprehending what it is you're trying to say to them, which then becomes a big communication problem on top of the ones that come from memory. I went over some of these, but this is sort of a list of, and I believe this presentation will be up on the website as well. The slides will be, so don't worry about furiously taking notes. But we do try to test a nice broad overview of functions that the brain takes care of for you. In some types of dementia, memory seems to be the first domain affected. In other types of dementia, judgment and problem solving are more affected on the front end. In yet other types of dementia, you'll see problems with speech and language being the very first presenting symptom. And then if you have cognitive problems related to stroke or brain bleeds, or other cerebrovascular type problems, you get an even completely different pattern, which tends to be a little bit more pervasive, unless you've had a very circumscribed stroke. So how many of you have a loved one who's had a stroke and has cognitive deficits? You have, and you have. Do you know sort of what area of the brain was affected?
Left frontal lobe.
Left frontal lobe. So,
Yeah, we,
okay, so language was probably affected.
language is fine.
Language is fine. Reasoning and logic and problem solving. Okay, gotcha. What about you?
My husband didn't have one until last year, but he had dementia for about 12 years.
Gotcha.
And the hour steps, which the doctor prescribed very early, he said, you know, when he tested him, this may be Alzheimer's. It is very early stages. It kept him able to take 3 lanyard classes.
Wonderful.
Last 2 years ago, for us to travel around the world.
Awesome.
And do all kinds of things
Totally worth
that
it.
I'm convinced that he would not have been able to do.
Sure.
Because I noticed, the very first thing I noticed was not memory so much as that he didn't understand something that I said to him.
Gotcha.
And he could repeat.
Sure.
I knew he heard it.
So it was a comprehension issue.
Comprehension.
Gotcha. The other thing you'll notice on this list is that we always assess mood as well, because mood, particularly depression, is something that can mimic dementia. When people are very, very depressed, particularly when they're over 65, it can appear as if they have dementia because cognition becomes very clouded. And so we want to rule that out as a possibility as well. But you can also have depression and dementia, and we're going to talk about that. And then at the end of the assessment, basically we provide a comprehensive written report of the results. I frequently will do a feedback appointment, go over the report in detail, talk about diagnoses, although again, the diagnosis is going to be much more robust after you've had an initial assessment and then a reassessment after a year or two, because then you're able to measure change over time. And the very definition of dementia is that we expect it's going to always get worse. And so if you measure a decline over time, then you've strengthened your argument that there is a dementia present. And do try to make very detailed recommendations for families. So the impact of the diagnosis, if you have a loved one or someone you're working with who has dementia, then you probably remember when that diagnosis came to you, or the first time you heard that word, or the first time you thought, maybe this is dementia. It's pretty intimidating. And once you have that confirmed, it really is like a grief process, because what you're grieving is what could have been or what you may lose. You know, there's a lot of trepidation that comes with a diagnosis of dementia. And so I listed here Dr. Kubler-Ross's stages of grief, because I see this a lot in families who have a loved one with dementia. The first stage being denial. They're sort of like, are you sure it's dementia? I think he's just been under the weather, or I think that maybe you need to check his blood work, or could it be some of these medications? And those could certainly be contributing factors. But then the second stage is anger for a lot of people, and you don't always progress through these stages in order, but anger at the unfairness of it, the fact that there are no good treatments for the underlying disease, that is incredibly frustrating. Bargaining is where you sort of bargain with yourself and with God, and you say things like, if you'll just keep him with me, or if you'll just make this not be the truth, then I'll go to Mass every Saturday. And, you know, that's kind of the internal bargaining stage that some people go through. Depression is a very normal stage of grief, and I see this a lot, not only with care partners, but also with people who've received the diagnosis. I can't imagine much worse news, because say somebody says to you, you have bone cancer. At least you know there's a treatment, and that there might be a resolution, and that there might be a way back from that. With dementia, in particular Alzheimer's disease, it's a pretty inexorable course, and that's a really sad thing. Even knowing that everybody progresses differently, and that some people progress very slowly and some people progress more rapidly. Some people are very, very happy until the very end. Some people struggle a lot with behavior problems. Even knowing that there's a lot of individual variability there, it's a really sad thing to get this diagnosis. So it's normal and natural for you and for your loved one both to experience some sadness as if you've had a loss. And then finally, hopefully, what we strive for is to reach some kind of level of acceptance where you sort of recognize this is our new normal. We've got to get about the business of managing this. Another interesting reaction that some people have to getting a diagnosis of dementia is to finally having an explanation for what's been going on. Because sometimes, especially in the early stages of dementia, when you've been a very high-functioning, intelligent person, and suddenly you can't remember the name of someone you've known for a long time, it makes you feel a little bit crazy. And so having an explanation that you have a neurological disorder, in some cases, can be a little bit of a relief. It's like, wow, at least now I have a name, I know what I'm up against, I know that I don't have a brain tumor, I know that I know where to head next. You know, I have a direction. Worry and fear are very normal as well, because it is unpredictable. Unfortunately, dementia, all types of dementia are very unpredictable in terms of how long people live from time of diagnosis until death, and also what their symptom clusters are going to be during the time that they're ill with this disease. One thing I notice a lot with people in the mild stages of dementia is embarrassment about the symptoms, that they make mistakes. And I've talked to people at length about this. So I talked to them about their new diagnosis of dementia, and they say, yeah, I just don't even want to go to coffee club anymore, because the guys are always saying, oh, I told you that already yesterday, and they call it to my attention, and it's just embarrassing. Well, embarrassment in some ways is really in the eye of It's inside of us, right? It's not something that other people put on us. It's something that we put on ourselves. And so my philosophy about it is, look, you have a chronic illness. You have a chronic illness just like your buddy has, you know, high blood pressure or heart problems. And so just talk about it and say, oh yeah, there's that memory thing I got going on, you know, I made a mistake. Tell me if I make a mistake. Because you really, and I'll talk about this again in a minute, you really can set the tone for how you respond to people and how they respond to you by what your philosophy about it is. And I'm not trying to sell you a line that you're supposed to feel rosy and all puppies and kittens about somebody having a dementia diagnosis. But attitude and perspective really do make a difference in being able to cope with having a dementia diagnosis, if you understand that distinction. And then people do sometimes, particularly in the mild stages of the disease, get a little more touchy, a little more irritable, because they're making mistakes, they're self-conscious, they're having brain changes that can contribute to irritability, and it's very frustrating when something that you've done very easily your whole life suddenly becomes difficult, right? So if you think about it, having a conversation with someone, you think of that as like, oh, that's easy. That's something that's so simple. And it's because it's an overlearned behavior. It's something we do every day. We have conversations with people. You say something, and then I say something back, and I think about what you said, and I respond, and then you think about what I said, and you respond. And in dementia, that becomes much more complicated, because not only do you have to remember the last thing that was said to you, then you have to very quickly process what it is you're going to say, and you have to find all the right words to say it. So then conversation suddenly becomes something that's much more challenging. And a lot of times that's frustrating, but it also can make people avoid having conversations. So in the mild stages of dementia, I will often hear people complain, yeah, he used to talk at our family gatherings all the time, and we couldn't get him to shut up, and now he won't say anything. And it's because a simple conversation may be intimidating to that person. The practical adjustment to a diagnosis of dementia, there's a lot of things to start thinking about, and it's kind of like taking on a project. For those of you who have loved ones in later stages of dementia, the moderate stage of dementia, or you've been living with dementia for many years, you know that it's kind of like taking on another project or another job. And there's some practical considerations you have to think about very early on. For a lot of folks, it's work. You know, I see people who are diagnosed with dementia, and they're still working. And so they have to make a decision about, do I continue to work? Evaluation, because they've been getting bad reviews at work. You're not remembering things the way you used to. You're not leading your meetings as effectively as you used to, and that becomes a reason that they go seek evaluation. There are people in the mild stages of dementia who still work. You know, there are in some jobs with some accommodations, ways that you could continue to do some work. I've known people in family businesses where in sales, or they own a store, or they own a restaurant, they're able to continue to work. It's much harder in the corporate world, and I think that's probably a lot because of liability issues. You know, you start to worry about, am I putting someone in an environment where they're putting themselves at risk by continuing to work? So that's a big decision on the front end. Hobbies too, you know, what if you're someone who, as your hobby, you fly small airplanes? You know, that's going to become a consideration because that's a pretty high-risk activity. And I just described to you how difficult just having a conversation can be when you are in the mild to moderate stages of dementia. So imagine taking on a high-risk hobby like flying an airplane. Well, you might want to sit down and really think about that. Driving is always an issue on the front end of dementia, and there are plenty of people who've been diagnosed with dementia who are still driving. And there's a subset of those people who probably can drive fairly safely on surface roads, and then there's a subset of folks with dementia who probably should not be driving. And one of the main reasons that people with dementia continue to drive who shouldn't be driving is that the family doesn't want to take the car keys away, or they've tried and it's become an argument, and this may have happened to you guys. Or there's someone who's living alone. So there's no one to kind of monitor their activity and to see that there's a problem there. There are actually driving simulator programs out there. If you're struggling with a loved one and trying to take the keys away, or trying to talk to them about giving up driving because that is a very high-risk activity when you think about it. There's a program, Baton Rouge Rehab Hospital actually has one that's called Drive Able. And you go and you take it, it's actually a computerized driving simulation, and it measures things like reaction times, problem solving, what do you do if a car's coming at you from this angle. It measures visual spatial processing that has to do with driving. What it gives you at the end is this really cool printout, I've seen it, that says, here's your risk of having an accident within the next year based on your results today. And then it also gives a recommendation, you should go have a live driving test. You should go sit with an actual driving instructor and see if you can pass the driving test. And I have actually recommended to people before that they go get the Drive Able or go do the Drive Able assessment, and they call back and they say, I passed. So sometimes, you know, it's not bad news. And I think that my point here is that having a diagnosis of dementia doesn't necessarily mean you have to stop doing everything, right? In fact, that would probably be the worst thing in the world to do, because then you give up all the things that you really enjoy and the things that give you independence. But there may need to be guidelines and assistance with some of the things you're going to continue to do. So for example, you might have a loved one that you're okay with them driving to the church and back every day, but not on the interstate. You know, and if they're willing to work within those guidelines, I think that could be workable. Living alone is another big question that I get. Is this person going to be able to continue to live alone, or do they need more intensive help? And there's lots of factors that go into thinking about that. The number one being safety. You know, I'm always, and I tell people when I talk to them, my number one concern is safety. I would rather err on the side of caution and make sure that you're going to be safe and that other people are going to be safe. And sometimes that means you can't live by yourself anymore, or that you need someone stopping in very regularly. And I try to be really honest with people about where I see their loved one on that continuum. Financial management, a lot of times people will present for evaluation because they're having trouble paying their bills. They can't balance the checkbook, or they forgot to pay the light bill and the electricity got cut off. These are stories that may be familiar to some of you. Or in much more severe cases, they've mishandled funds and money has gone mysteriously missing. Someone may have taken advantage of them or convinced them to hand over money. And then other what's called instrumental activities of daily living. Those are things like paying bills, getting out and functioning independently, being able to cook a meal. You know, these are things that we think of as being very easy, but as I mentioned, when you have even mild dementia, it can become more complicated and difficult. So what can you do to cope not only with the diagnosis, but also this adjustment that you're having to make? My first piece of advice to you would be keep up with normal activities. If you received a diagnosis of dementia today, you are not a different person than you were yesterday. You're still that same person. We just need to be more thoughtful going forward about what your activities are going to look like. You may also need to find new activities that are more appropriate to your new normal, where you are right now. And so you mentioned before that, you know, he was able to take some courses and you guys did some traveling. You can take on new things. You know, you can go see new countries. You can take pottery together, or whatever fun, wine tasting. That one always looks really good to me. It's like, they have a class in wine tasting. I need to sign up for that. Also, you have probably noticed, if you're living with someone who has dementia, that memories from yesterday go very quickly. Memories from 30 or 40 years ago stick around until the very end. And that's because a long-term memory is stored very redundantly in your brain. Your brain is a little bit like a computer. And when you're remembering your wedding day from 1950, you probably bring it up as a memory and talk about it over and over again, right? So you're like, oh, remember our wedding day, and this happened and that happened. Well, every time you bring it up and recount it to someone or remember it again, it gets stored away in another redundant place in your brain. So that when the brain does start to deteriorate or decline, it's like there's several memories of that one wedding day tucked away, and it's easier to call those back up than it is to remember what you had for breakfast, because that memory didn't get stored away very efficiently. because of the nature of the disease. So that's why reminiscing is great for people who have dementia. And a lot of day programs for people who have dementia center around this, playing the music of the 1940s and 50s and 60s, which is very familiar, creating memory books, where you look at pictures, old pictures, people whose names you can remember, mom, dad, grandparents, that sort of thing. And really, in many cases of dementia, social skills are pretty well preserved until the end, unless it's a case of frontotemporal dementia, which is a very specific kind of dementia. In frontotemporal dementia, what you see is social skills go out the window very early on in that type of dementia, and people become very unaware of social rules and say things that may be inappropriate or very, very inconsistent with who they're known to be as a person. Another great tip for any stage of dementia is having a routine. It's making sure that you're doing the same thing over and over again. Mondays are always golf day, Tuesdays are always when we take the grandkids, Wednesdays are always this. We always get up at 7 a.m. and have breakfast together, because routine becomes an overlearned behavior for someone with dementia, and it breeds familiarity and comfort for them. So, and it also gives you something to expect. Along those lines, you can put together a memory station in your home, which I find is really a useful way to cope with the memory lapses that come with dementia, is to have, just in the kitchen, have a big board where you've got a big giant calendar that says, what are we doing this week? And I'm not talking about like they have it at kindergarten, where there's a sun for a sunny day or anything like that. Really more just like a regular old calendar, so that if your partner or mom or dad has questions about, now when is that appointment? They can just go look, and it becomes the place where they can always just go look. You can leave notes for them that say something like, I'll be home for lunch, so that they can go to the memory station and sort of see, okay, I know what to expect, if they're still able to comprehend language and remember to go and look at that memory station. Pictures of familiar people. So for example, if you've got people coming into your home to help provide care, you could have a picture of that person with their name underneath it, if the name recall is a particular problem, and that way they can always have it just right there on this memory station or bulletin board. You can have the date and the year, so that they're always feeling more oriented to where they are and what they're up to. Enjoyable activities, I'm a fan. I think that everybody should be doing things they enjoy. Life is short, and it's important for you to have fun, and that doesn't, a diagnosis of dementia doesn't mean that you stop having fun. There's still ways to have fun and to laugh and to do things that you enjoy and that your partner with dementia enjoys as well. Two important things, and I just mentioned this about being the same person. You're not a different person than you were yesterday just because you have a dementia diagnosis. And it's really important for both the person with dementia and the care partner to remember that none of this is your fault. This is a neurological disorder. It's like being diagnosed with heart disease or cancer. It's a chronic illness that unfortunately doesn't have effective treatments like many other chronic disorders do, but you live with it instead of letting it become the defining characteristic of your life. Prioritize, if you're a care partner with somebody with dementia and you have a list of 18 things to do today, you've already sabotaged yourself. I think what you might want to do is have one or two things that you want to get taken care of in any given day, particularly if they involve your loved one with dementia and you have to get them mobilized and out of the house and out of their routine, but then also have a list of things that'd be nice if you got done. Because just from a mental perspective, you don't want to set yourself up for failure by thinking, I can get this done and this done and this done. No, just pick one or two things that are really important to get done, and then the other things become gravy. And then you just feel even more accomplished when you get them done. It's kind of an interesting exercise if you're living with someone who has mild stage dementia. If you actually sit down with a 2-column sheet of paper and write down the things that have become more difficult and the things which are still easy. Because sometimes when you have memory problems, it feels like everything is difficult. But it's really not. Usually there's preserved abilities, things that they can still do, and it's a little bit of a mood booster to highlight that for the person who has dementia. It also helps you identify tasks that you may need to reallocate or get rid of, or, you know, if laundry has become too difficult, don't do laundry anymore. Get someone else to do the laundry, but you can still do this. You know, you still do a great job of putting the dishes in the dishwasher, you know, that kind of thing. Take breaks, and that applies for the care partner and for the person who has dementia. You want to make sure that you're taking timeouts. I actually have 2 young children.
Hello.
Excuse me. No problem. Come on in. I have a 7-year-old and a 10-year-old, and at my house we have mommy timeout, where I get really frustrated and I say to them, okay guys, I put myself in timeout, and I go behind the door and I shut the door and I just take a couple of breaths. Okay, they're children, their brains are still developing. And then I come back out and they're like, was it a good timeout, Mom? Like, do you feel better? Do you know what you did? They get a big kick out of it. And so it has become kind of a joke at our house, but it really works. Because sometimes you do need to step away, even if it's just for 5 minutes behind the door, and just take some breaths and do some relaxation. For a person with dementia, it becomes really important for them to tackle one task at a time. So say you're living with someone in mild stages of dementia, or someone you feel comfortable leaving at home by themselves, and you leave them a honey-do list. Make sure that it's very concrete and that it's only got a couple of things on it, and that it's not do this, then this, then this, then this. Write it down so that they can remember it. And if they go to the grocery store, give them a pretty short list, make it very concrete, and don't be surprised if they still come back with not all the right things. Also, you as care partners probably know what triggers stress for you and what triggers stress for the person you love who has dementia. Sometimes it's crowds. You know, that can be really stressful, again, because there's so much information coming in and the brain is not as good at deciphering all that information. You may have triggers, certain behaviors that your loved one with dementia exhibits that tend to really wear on you and make you stressed out. So know what those triggers are, and then if you can, make a plan for them. So if it's crowds, then maybe you want to avoid Bayou Country Superfest with the person who has dementia. For you, if it's a particular behavior that your loved one exhibits at night, make sure that you're in a real good place when nighttime rolls around, or that you have some help maybe when nighttime rolls around, if that's a time when behaviors become a problem. And then there's this idea of stress resilience, which I think is really important for all of us, not just people caring for loved ones with dementia. Stress resilience means you make yourself resilient to the effects of stress by doing things like exercise, and this is great for people with dementia as well, as long as it's safe for them physically to be exercising. Nutrition, things that you put into your body, and then also sort of emotional and spiritual resilience as well, making sure that you're getting support when you need it from sources that mean a lot to you. Let me just say a word about exercise. Exercise is a cognitive enhancer. So the medications that some of your loved ones may be taking, Aricept, Exelon, Namenda, those medications boost memory or are considered cognitive enhancers because of something that they do to the brain chemically. Exercise is a cognitive enhancer. We're learning more and more just in the past 20 years how important exercise is for cognitive functioning. In fact, there's a study that was published within the last 2 years that looked at people diagnosed with Alzheimer's who exercise and people diagnosed with Alzheimer's who were sedentary. And the people who were sedentary progressed more rapidly in their disease and had lower scores on cognitive tests than the people who exercise. So we know that exercise is a really important resilience factor. It helps keep your brain resilient. So just a little note, we're all gonna go walk tonight. Not in the rain, treadmill tonight. So, okay. Water aerobics, there you go. Talking about dementia, I have a very strong opinion about this, which is that, well, I'm a talker first of all, and I'm also a really direct person. And I think that in the case of dementia, the more you talk about it, the better. The more you talk about it between you and your loved one who has dementia, the more you talk about it with people you know, the better. Because what you do is that you're demystifying it. You're setting the tone for what that conversation is going to be like. And I'll give you an example. I actually have a little stutter, and it's not bad. Most people don't notice it, but it gets worse if I take cold medicine. So on days that I take cold medicine, I really bop around a little bit with my speech. And when I'm talking to people, if I notice that I'm stuttering, I'll say to them, oh, that's my stutter, sorry, I stutter. I took some cold medicine today and it's worse today. So I've just set the tone for them. I've just talked about the elephant in the room. They notice I have a speech problem, it's very mild. And I've just said it like, I'm not worried about it. And I think that puts them at ease, right? So if you have a memory problem and it's evident to other people, you can say, oh, I have dementia. That's that memory thing. It's really annoying. Sorry about that. Then you've set the tone for the conversation, and you've demystified dementia a little bit, because I think the word dementia is something that conjures a real specific image for us. And so you can say, hey, I'm a person living with dementia, or I have a dementia diagnosis. And the more you talk about it, the better, because you're getting it out there and nobody feels like there's an elephant in the room. And it is a chronic illness like many other illnesses. If you're talking to friends and family about dementia, I think it's particularly helpful for you to not only answer any questions they have, but then be really specific about how they can help. So if you have a real specific need, for example, in the instance of there may be some behaviors at night that are harder for you to deal with, you can say, well, the way you can help is if you want to come hang out at 7 o'clock every night, help us wind down, that would be great. Or if you could come over at 7 at night and let me catch a little break or watch, Walking Dead or whatever, I don't know, whatever. What's another show? Oh, Downton Abbey. Let me catch Downton Abbey. Oh my gosh, that finale. Anyway, be really specific about ways that people can help you, because people do want to help. You probably have people who've offered you help. They may not be capable of coming over and sitting all day with someone just so that they aren't by themselves, but they might be able to do something like run by and pick you up some canes, or come give you an hour's break so you can get your hair done. And you can decide who to tell. I'm not advocating telling everybody in the whole world, but certainly within your circle of friends, the more that you give that information out, the less you're going to feel stigmatized by it or feel like it's something to be ashamed of, which it's not. Information gathering, that's what you're doing right now. You're trying to keep yourself constantly learning, not only, I'm sure, about the most up-to-the-minute information about what we know about dementia, the drugs that are coming down the pipeline, but it's really important on the front end, once you've had this diagnosis, to assemble what I would call a care team or a care partner team. You want to have a doctor you feel really comfortable with, who can prescribe medications for you. You may also want to get connected with support groups, particularly caregiver support groups, because it is very powerful, and some of you may have experienced this. It's very powerful to be able to talk to someone who is going through the same things that you're going through. Even if you don't come up with the perfect answer, just to hear somebody else has to deal with X, Y, and Z, that's kind of a relief. It's like, oh gosh, I'm not the only person in the world who has to tell my wife the date 18 times in one day. Like, how do I deal with that? There's a lot of great community resources. You're taking advantage of one of them here at Pennington. We also have Alzheimer's services in the capital area. They put on a lot of educational type programming. They have a library where you can go and check out books about dementia. They also keep a referral list of people who specialize in working with older adults and with people who have dementia. And a lot of information is available out there on the internet. I'm on the internet every day just finding resources for people who come to my office, books that I want to recommend to them. I just print the receipt. I'm like, here it is on Amazon, $14. Take it, So the internet's really invaluable. And if you're not able to get out of the house and go to a caregiver support group, there's a lot of bulletin boards and chat rooms where you can post messages. Or if you're embarrassed about something that you want to ask, if it's something really personal, you can put it out there anonymously and see what people say as well. So the internet, I think, if you're comfortable with the internet, it's a great resource. And then there's books and workbooks I recommend very regularly. One of them is for you guys living with individuals who have dementia. There's a book that came out within the past 2 years called The Alzheimer's Prevention Plan. And it summarizes a lot of the up-to-the-minute research about what we know about modifiable and non-modifiable factors, things you can do something about and things you really can't change, like your genes. You can't change, I don't mean these genes, like the genes in our bodies. And then modifiable factors like exercise and diet and how you treat your body, and cardiovascular risk factors, those sorts of things. So that's a really great book, Alzheimer's Prevention Plan. There's another book called Living with Mild Cognitive Impairment that's just come out in the last 2 years, and it really targets that questionable column, the column of folks who are having some mild problems but haven't been diagnosed with dementia and may not have dementia. But it talks a lot about how to compensate for mild problems in day-to-day life, so it's a good resource as well. Family dynamics, really in the early stages of dementia, you may notice that family dynamics don't change that much. You've got your same loved one, they're the same person, but they are having some trouble with memory or having trouble remembering things, and you can help them with that. That's not too difficult. But you may also notice in the early or in the mild to moderate stages of dementia that there are even more changes that happen with the family dynamic. So with spouses, you're thrown into a role where you're a caregiver for someone who may have been a caregiver for you your whole life, or been more of a protector or a partner. And so the dynamic shifts, right? You become someone they have to answer to, or they have to do what you say so that they can be safe. And they have to take these pills because it's good for them. And so for a woman who's living with a husband who has dementia, you become more like a mother. And that's a huge shift that happens a lot in the movement from the mild to moderate stages of the disease, when people become a lot less independent. And it really becomes less of the marriage that you probably always dreamed of and hoped for. And that's a really difficult emotional adjustment, and you may find that you move through those stages of grief again. You may find that as the dementia progresses, you have to sort of revisit that whole sadness again, because the person's gone from being able to do these things, drive themselves, take care of grooming, dress themselves, watch the grandkids, to not being able to do those things, and has become much more dependent on you just for basic safety and care. And that's a grief process. You need to allow yourself to feel appropriately sad about it, and just see this as a shift in the dynamic. A lot of couples will describe to me that they they feel more like friends at that point. That this is a person I've loved my whole life, and now I'm really going to be a friend to him. I'm really going to pick up when he needs it and be his friend. I think that can be helpful, because the role shifts, but you still have that love and care and concern. Of course, sexuality changes dramatically with dementia, not with aging. We know that people over the age of 65 are very sexually active in many cases, but when you have a partnership that is becoming more of a caregiver attendee situation, it's harder to have that intimacy. And so that's another hurdle that couples sometimes have to overcome in married couples or partners, is that your romantic life changes. You're still affectionate, and your spouse may still want to hold your hand and dance and hug and kiss, but sex is so intimate and it's so personal that it's really difficult when you have a skewed dynamic to be sexual with someone, and that can be a loss that you have to mourn as well. This can be really frustrating for some folks. Changes with the relationship with adult children. Have you guys heard the term sandwich generation? So I'm a sandwich. The sandwich generation, that's a term that's used to refer to people who have young children still at home, which I do, and parents who are in need of more and more support for various reasons. And so we're kind of caught in the middle of the sandwich. And my mother-in-law actually had Alzheimer's disease and passed away 2 years ago. And we were at a point when she passed away that we were considering having her move into assisted living. She lived in New Orleans by herself. And we had people in the home, which was really great, and extended her time in her home, which is what she wanted. And then I think she caught wind of the fact that she was about to have to come live in Baton Rouge in assisted living, and she kicked the bucket. She's like, I'm not leaving my house. And she did. She died in her living room. She had hospice care and died in her living room, and it was the ending that she wanted, which we're all very grateful for. But it really does change your relationship with your adult children. I'll never forget the day that we were sitting around the table. I say we, myself, my mother-in-law, my husband, his brother, and his brother's wife were sitting at the table. And they were all staring at the floor, waiting for me to tell her that she couldn't drive anymore. And they were all just sort of like, what's this? Did you get that? And I'm like, Joy, I got some bad news for you. We just really feel like things have gotten to a point where, it's not safe for you to drive anymore, and your safety is the most important thing to us. And everybody cried, and she was very upset. But it was impossible for my husband and his brother to say that to her. That was their mother, and they respected her, and they had a really hard, they're like, can you do it, please? Can you do it? I'm like, I'll do it. So it really, that dynamic shift between adult parents who have dementia and their children is very awkward, because you're used to, this is the person who raised you, you looked up to them your whole life, and now you're put in a position where you really need to be their advisor and their care partner, and to help guide them so that they're safe and that everybody else is safe. And that can be a real challenge. I can't even imagine saying those things to my dad. I've already tried to get him to move to Baton Rouge. I'm like, Dad, come on, move to Baton Rouge. My mom would come in a heartbeat. My dad's like, no, all my doctors are in Mississippi. Dad, we have doctors here. But he's stubborn and determined, and those are the things I have always admired in him. He's incredibly independent, and he's very, very accomplished, and anytime I mention moving to Baton Rouge, he takes it very personally. He thinks I'm trying to keep a closer eye on him, so I'll keep you posted about that. But the way to deal with it is you just have to keep communicating to them that message of love and care and concern. I'm not trying to demean you. I'm not trying to take away all of your independence. I love you and I want you to be safe. I really think that's a powerful baseline message to give. Let me talk a little bit about sadness and depression, then we're going to wrap up. I mentioned before that sadness is really common, especially in the early stages of dementia, that it is not happy news for someone to tell you that you have dementia or that your loved one has dementia. There's a line that exists between kind of that natural, I'm sad because I was diagnosed dementia, and then tipping over into depression that might need more attention or might need medications. And so mild depression is common, especially when a person knows they have deficits. That's frustrating as heck. Particularly for people who may be sundowning at night or getting sort of exhausted by the end of the day and becoming more irritable. There's some data which suggests that irritability can be helped with the antidepressants. Anxiety medications, the particular class I'm thinking of is the benzodiazepines. That's Xanax, Valium, Klonopin, those drugs. Those are actually have to be used with caution in people who have dementia, because they can make you foggy. They can make you a little more confused, and when you don't have a full gas tank in terms of memory and cognitive functioning, you don't want to further penalize the brain in that way. And so that's something to discuss with your physician and see if that's something that's worth the benefit versus the risk of it. And then sometimes people really do need individual therapy, whether it's you or the person with dementia. I've had people with mild dementia in therapy with me. There's a level of insight that I think is very appropriate for therapy. It helps them to start to adjust to that diagnosis. And it also normalizes the experience for them. They don't feel quite so isolated and alone if they have someone to talk to who's not in their family. Because when you get the diagnosis, the whole family gets the diagnosis, really, right? And so it's nice to have an objective outside party that you can talk to at times. When you should be a little more concerned would be if the person starts talking as if they feel worthless, like, I don't know why you bother. it would be better for everyone if I just weren't here, this is just too difficult. Lots and lots of tearfulness, particularly if it's accompanied by sadness. Sometimes with dementia, you can get just a little bit of emotional lability, particularly if there's a stroke involved or cerebrovascular problems involved. People will become what we call labile, and all that means is up and down emotions. They can turn on a dime. That's actually a brain problem. But if people are crying a lot and expressing sadness, I don't like my life, I don't feel good, I feel sad all the time, that's a time to go talk to your physician about what could be done next. Loss of interest in regular activities, that's another one of those that's on the fence there, because some of the changes that happen with dementia include loss of motivation, loss of initiative, especially as you progress from mild stages into moderate stages. And so I'll have folks come in and talk about their loved ones and say, gosh, they sit on the couch, I can't get them to go to coffee club, and they just sit with kind of a blank stare, and I'm worried that they're depressed. Well, they may very well be depressed, but also when you have problems with your brain is, particularly the front part of your brain, is involved in drive and motivation and initiating activities. And so you may not be as prone to initiate activities because of the brain changes that are taking place. So that's sometimes difficult to tease apart. If you see any dramatic changes in sleep or appetite, that's always a great time to go see your physician as well, and just kind of check in with them about making sure there's no medical issues going on that are undetected, or if they're, someone's sleeping all the time or not sleeping at all, that might be an indication of a mood problem that needs to be treated. And then, of course, any kind of talk of death, dying, suicide, that's not just life is short, that's fine, then you want to consult a professional. So I talked about dementia-related mood changes, particularly when people move from that mild to the moderate stage of dementia. You can see more changes in mood and personality. So people who were very easygoing become more irritable and demanding. I've even talked with folks who had irritable and demanding spouses who became much more amenable. So sometimes that happens. Sometimes you'll develop anxiety symptoms, particularly separation anxiety. If you think about the moderate stage of dementia, and I know some of you have loved ones in the moderate stage, in that stage of dementia, it's almost like you've been sort of taken out of Earth and plopped on another planet where you don't speak the language and you don't know what their customs are. And it's very disorienting. That's the way I like to think of it. And so it's normal for you to hang on to anything that looks familiar, and that's sometimes why people have separation anxiety. In terms of communication, we talked a little bit about talking openly about feelings and what's going on with you. But you do have to recognize that particularly as dementia progresses, people will have more problems with expressing themselves and with understanding what it is that you're trying to say to them. So communication won't be the same as it's always been. You may not have deep conversations anymore, but you can still talk about what's going on, involve your loved one in decision making, and then make sure that they know how you're feeling too, because that's important. I think I covered a lot of that. Really just make sure that you're getting support, whether it's from support groups, from your family, from friends. And when I say support, I mean everything from a phone call, a text, a breakfast, somebody bringing you canes, to having somebody help you get a weekend away. That can be any level of support. And then find what works for you and your family, because every situation with dementia is going to be slightly different. That's why it's so important to have a good team you feel comfortable with, physicians and therapists